Hey guys, on for more complex questions, and these ones specifically are over EKG and dysrhythmias. So this is a topic I also talk about in adult med surg, but if you were an adult med surg, these questions are going to be a little bit more higher level or over rhythms that are covered in complex, not adult. So if you are in adult med surg, this is not the video for you. I have other videos. You can look for them other places. Look for the med surg playlist. But for those that are in the right place, again, these videos are here. I will give you my disclosures. Is one, I do not consider myself the end all be all. I created these questions myself. So I can make errors. It's always possible. Whatever your teacher says is the gospel or the Bible. You're always free to reach out to me if you find any problems and stuff in my questions. Then also, just that the purpose of doing this is to look at content, yes, but also start getting some of that test taking strategy. So hopefully this will help you to start figuring out how to tackle some of these really challenging questions. So let's jump in. All right, question number one, and yes, there will be EKG strips, but I'm not going to spend all my time about interpretation. So just know that I'm going to talk about about kind of how I look at the rhythm real quick. But if you want more help with that, I have other videos. So it says a nurse is caring for a client in the following rhythm. What is the priority action? So when it comes to EKG stuff, people always ask what kind of questions could you give? And so we can give a question where we give a strip and we say, what do you do about it? We can give you a strip and say, what is it? We can describe a rhythm and say, hey, what is this rhythm? We can describe a rhythm and say, hey, what are you going to do about this rhythm? And you're going to kind of see as we go through these questions, there's a variety of questions that can be asked. But you always need to see, okay, what am I looking for? So in a question like this, I need to figure out one, what is the rhythm? And then two, what am I going to do about it? So first, let's figure out what the rhythm is. So I'm looking at this rhythm and I'm counting. First, I'll start to see, what's my rate? 1, 2, 3, 4, 5, 6, 7. It's 70. It's regular. I see a P wave for every QRS. I see a skinny QRS. So everything seems normal. The only thing that seems off is that my PR interval is greater than one of those boxes. And so here, let me see if I can get over here. Hopefully you can see this. But you take one of these red boxes, with the outline with the red, and if my PR interval, which is the beginning of this P wave to this pointy thing, if that's longer than one of these red boxes, it is a block. And so if everything is normal, but the only thing that's abnormal is that I have a long PR interval, I have a first degree block. So really what this question is asking is, what is the priority action for a patient in a first degree block? So I have to know, okay, well, this is going to be one of those questions where I'm figuring out, do I need to do something right away, or is this stable and I can just watch it? So the first one is call the physician immediately to report this finding. And anytime you have this as an answer choice, you always want to then ask yourself, okay, if that's an answer choice, this means this is either really serious, or I need to decide, do I take action first or assess first? So if I don't know, I'm going to keep going, but that kind of cues me in my head that this could be an emergency. I either need to, call the doctor immediately. There's nothing else I can do, or I need to take action first. Because before you call the doctor, you should complete any necessary assessments. Because if I'm about to call the doctor, but they're going to be like, hey, what are their breath sounds? Or what's this? There's no point in calling the doctor. Not yet. No point in calling the doctor at all, but there's no point in calling the doctor yet. I need to complete any necessary assessments before I call the doctor. And then if there's any actions that I need to take immediately to take care of this patient, that if I call the doctor, it would delay life-saving treatment, I need to do those first. So I either need to do assessments that are key so I can tell the doctor everything they need to know to make a good decision, or I need to take action for this patient to prevent something that is life-threatening. But again, that's just if that's the actual problem. Sometimes we throw these in here and there's no problem. So let's keep going. The second one is prepare the client for surgery for pacemaker insertion. So I do know for blocks that we do like to use pacemakers as a treatment, but this rhythm's pretty normal and it's only a first degree, which is the most mild one. So I don't know, that seems like something for later on. There's nothing to show that this patient's unstable or that they're having any any issues with their blood pressure, any issues with perfusion. The other choice is document the finding and monitor for changes to the rhythm. So this is the opposite of A. And so a lot of times when there's two answers that are opposite, like call the doctor right now, or hey, it's cool, just watch it. A lot of times that's kind of your cue that maybe one of those is correct. So sometimes when they're, not always, but sometimes when there's opposite answers like that, like two extremes, one of them is going to be correct. So you could kind of look at this and say, hey, maybe it is either really serious or I'm going to just keep watching it. Then D is set up for immediate bedside cardioversion. Well, the one thing is it doesn't seem like it's that serious. Like it's kind of going back to B. It's very similar to B. But also you have to consider cardioversion. That's to get someone back to a normal rhythm. And this is a normal rhythm. I can't cardiovert someone who's in a normal sinus rhythm. And so at the end of the day, that doesn't seem like it's an option. So now I'm down to A and C. So then I just have to figure out, okay, first degree block, is this something I need to call the doctor right now? Or is this something I'm going to document and continue to monitor? And in this case, the correct answer is C, that I'm going to document this, a first degree block, we watch it. If it progresses to second degree or a third degree, we're definitely going to take some action, but first degree can be harmless and you can live your whole life with it, no problems. So yeah, it does not require immediate call to the doctor. All right, so number 2, a nurse is assessing a client on the cardiac unit. The client complained of sudden chest pain and becomes unresponsive. On assessment of the cardiac monitor, the nurse finds a flat line with no P waves or QRS complexes, and the client has no carotid pulse. What is the priority action? So this is one of those questions where we're talking about a rhythm, but we're describing it to you. So you have to know what these things are and what they're supposed to look like. So they had sudden chest pain and they're unresponsive. That's never a good sign. That usually means emergency. I need to do something right now. It says that there's a flat line, no P waves, no QRS complexes, and no pulse. So what's the priority action? So it's pretty much saying if I have a patient in cardiac arrest, flat line, there's no electrical activity, what do I do? So my first choice is to give atropine IV push. So atropine helps to speed up the heart rate, but if I don't have a heart rate to speed up, I don't know how helpful that will be. So I'm going to move on to the next one. It says give IV saline bolus. Well, I don't know. They probably don't have a blood pressure. I can fill them up with fluid, but if there's no heart to pump to circulate the fluid, it's kind of pointless. So I'm going to say no. Begin high quality CPR. Now that sounds like the best option so far because I need to start circulating. And it seems like that what this question is really asking is how do you respond to asystole in a patient? And you respond to asystole with CPR. And the last one, prepare for defibrillation. So this is where they're going to get you because you're like, oh, defibrillation. Which rhythms do we defibrillate? And if I remember correctly, we can defibrillate anyone who has no pulse, but some sort of electrical activity. So they have to have something like VFib or VTAC or they have to have some sort of electricity going on in the heart. They cannot have a flat line. We cannot shock asystole. So if this question is really asking what the treatment for asystole is, the only things I can do is start CPR. Another correct answer that's not on here, another one that would be a correct answer would be like giving epinephrine, things like that to get things restarted. But effectively, I'm going to do CPR, epinephrine, continue that hope that either they go into some sort of rhythm with electricity where I can shock them, or that we just start to get a spontaneous rhythm or spontaneous return of circulation. So effectively, this is saying, what are we going to do for asystole? And the first thing or the priority action is going to be to do CPR. So sometimes priority action questions are going to have all right answers, and you're going to have to figure out, okay, well, which one is the most right answer? And sometimes priority actions there's only one that's actually correct. So just know for this one, the only actual correct answer is C. It's not just that we're going to do these other ones. Now it's possible that depending on circumstances, if we got some, electricity back or got, they returned and got circulation back, we might do some of these other things. But when someone has asystole, the only things we can do for them is CPR and epi. There's other treatments in the protocol too, but I'm just going to focus on those two to keep it simple. So a client with a history of a first degree AV block. Oh, you guys love blocks. Is being monitored on continuous cardiac monitoring. During the nurse's assessment, the client had a change to their rhythm and is now in the following rhythm. What is the nurse's understanding about the following rhythm? Sorry for all my coughing and interrupting. It's the summer cold from all the weather changes. But don't worry, water makes it better. Oh my goodness, I'm dying over here. Anyway, so this one gives me a strip. So first I have to identify, okay, anytime there's a strip, I'm most likely going to need to interpret and figure out, okay, what is this rhythm? So first I got to figure out what the rhythm is. And then it looks like the answer choices are like names of rhythms. So pretty much what this question's asking me is, what is this rhythm, or what the heck is going on? I had a first degree block, and then they went into this rhythm. So let's interpret this rhythm. So more than likely, if they're in a first degree block, they went into some other type of block, because usually blocks progress. So if I look at this, when I look at a rhythm like this, I see extra P waves. So I know it's not a first degree block because there's extra P waves. It's irregular. So since it's irregular, I know it has to be a second degree block. Third degree blocks are regular R to Rs. And so it has to be a second degree block, but to differentiate whether it's a second degree type 1 or a second degree type 2, what I'm going to do is look at my PR interval. If my PR interval is the same, and the PR interval again is this interval from the beginning of the P wave to the QRS, if this is the same all the way through, it's not getting longer, then I have a second degree type 2. If it's getting longer and dropping, then what I have is a second degree type 1, which is that winky box. So this one, it looks like it's staying the same and then just randomly dropping, same, and then there's probably a drop here. So it's like same, drop beat. So it's just a random drop beat. So this would be a second degree type 2. So I can easily find my answer here that it's C, because that's the only choice. They didn't even have second degree type 1 as a choice. But we could go down just to kind of look at these. The client has converted to a junctional rhythm. Well, in order to have a junctional, because I think that when you're studying, I always recommend, even if you know, you're like, oh my goodness, I know this is the right answer, look at the other answer choices that can help you study and figure out what else you might need to know for the exam. So it says the client has converted to a junctional rhythm. Well, this can't be a junctional rhythm, because what do you need to have a junctional rhythm? You need to have upside down, hidden P waves, or P waves that are have a really short PR interval. And so that does not apply. I have a normal PR interval here. My P waves are upright. They're not hidden. The client has a first degree AV block with frequent PVCs. Well, there's no PVCs here. There's just frequent P waves, which means they're having some other sort of blocks. This one can't be correct. It says the client is trying to convert back to normal sinus rhythm. It doesn't look like it. It looks like the rhythm is getting more severe, not more normal. So it seems like the best answer here, even if I wasn't able to identify this as a block, is that they're progressed to a second degree type 2 AV block. Question 4, a nurse is caring for a client with supraventricular tachycardia. The doctor prescribes adenosine. Which of the following statements about this medication is true? So this is another kind of questions we can ask. We can ask you a question about treatment, like medications, and how we're going to need to manage those medications. So let's see if we can, this is like a true false question. So it's saying this medication is only used if cardioversion is not effective. So it's trying to see if I know whether we do meds first or cardioversion first. And this is saying you do cardioversion first. Well, cardioversion is much more invasive. So I would think you would do meds before cardioversion. So I don't like that statement. I'm going to say no. This medication will help fix this rhythm by increasing conduction. Well, conduction is electricity. So in supraventricular tachycardia, do I want more electricity? It seems like I would want less electricity if it's a tachycardia. So that doesn't seem to make sense. So I'm going to say nah. This medication needs to be administered via rapid IV push. Well, I don't like that word rapid. That's very extreme. But I know this medication has some special precautions. It's the only one that I'm not sure about, or I'll say maybe so far. And then this medication can only be given through a central line. Well, what do you call them? I'm going to say no. I don't think this is one of the ones that you need a central line to give, because otherwise, I mean, people get this rhythm all the time. And if they're sitting there waiting for a central line to get this med to save their life, I don't think that that'd be very wise, but you know, it doesn't seem as reasonable. So, and the correct answer is C, that this is administered rapid IV push. So adenosine effectively with supraventricular tachycardia, we always want to do least invasive first. So I'm not going to talk through all of them, because I think I might have the next question has to do with treatment, but we do least invasive first. And if we try there's a lesser invasive option than medications. I'm not going to talk about it because it'll give away for the next question. But if we try that and it doesn't work, then we go to adenosine, or if the patient's unstable. So we're going to try it. And so what we do is this is the only medication really that we want to give rapid IV push, except if you're in a code. But what we do is we sit there and we literally slam in the adenosine and then slam a flush behind it. And it has to be given that way, because what adenosine does is, think of it like when your computer or something's not working and the IT person's like, hey, turn it off and turn it back on and see if that works. That's what adenosine does, is like your heart is in this rapid rhythm, can't get out of it. So let's try turning it off and turning it back on and see if when we turn back on, that then it's going to start working right. What do you call it? That's what adenosine is. And so it's very scary. So the one thing that it's scary as a nurse, because literally you're sitting there holding your breath, because literally their heart stops and you're hoping it restarts. You have to have a crash cart at the bedside. You have to be ready to perform CPR and start ACLS protocol if their heart does not restart. So you're hoping to goodness it restarts. But yes, that's what adenosine is. And a lot of times they restart in a normal rhythm, which is great. But yeah, so that's adenosine. But the only thing that is true here is that it has to be given rapid IV push. And now usually most of the time, I know I've talked in other videos that like the word rapid, it's really extreme. We usually don't like words like that, but this is the one time where it might be okay. All right. So a nurse is caring for a client with a rhythm below. Their blood pressure is 125/77. Their respiratory rate is 20 breaths per minute, and their oxygen saturation is 95% on room air. What is the priority nursing action to take? So here's a strip, which means I'm going to need to interpret this strip, but there's also vital signs in the question. And this is really important for me to notice, because one of the things I want to notice, I'm reading it, when I'm doing any sort of dysrhythmia question, I want to see, is the patient stable or unstable? Like, where are they at? In this patient, they have a good blood pressure, normal respiratory rate, and their oxygen saturation is good. So this patient is stable. And that's how I tell, because like people, I'm not saying that like, hey, a patient's in VTAC, but their blood pressure is okay, so I'm not going to treat it. But what treatments we go to, or like how invasive we're going to be with our treatments, a lot of times is based on how the patient's tolerating that. If a patient had this rhythm and had a blood pressure of 70/50, it's very different than with them having a blood pressure of 125/77. So I always have to keep in mind, like, how stable is the patient? How are they doing? And at this moment, this patient seems like they're stable. So I always, again, if they're stable, then I'm going to do least invasive first. If they're unstable, I'm going to go and do probably the most invasive thing first, because I want to treat this rhythm, because they are not tolerating it. Because remember, dysrhythmias all go down to poor cardiac output, that I'm not getting blood flow out. I cannot breathe. I cannot think. I cannot process. I have no blood pressure. It's a mess. So at the end of the day, that's kind of why we have to go to, it kind of shows us where we're going to go. So then I have to go back. And like I said, there's a different type of treatment I can try that's less invasive than the adenosine. But that just gave away one of the answers not being correct. But let's see if we can go through this. So anyway, first I have to figure out what this rhythm is. And I kind of already gave it away because I said that I had another question on SVT, but let's go through my handy dandy little trick. So let's look through this. First, I'm going to count the rate. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, almost 18. So it's like 170, 180 beats per minute. So it's fast. And remember, once you get above 150, we're no longer sinus. And the QRS is skinny. So this is not a ventricular rhythm. This looks like a supraventricular rhythm. I can't see any P waves. So this is where people get confused. They're like, oh, there's no P waves. What do you call it? But there is P waves. It's just moving too fast for you to see them. So there are P waves there. You just can't see them. So this has to be, if it's fast and skinny, it has to be supraventricular tachycardia. So what am I going to do for supraventricular tachycardia? And also I should say, like, supraventricular tachycardia, fast, skinny, and regular, like the ventricular rhythms are going to be more irregular. So am I going to grab the defibrillator for immediate synchronized cardioversion? Well, that's one treatment, but I don't know if that's going to be what I do first. They're pretty stable. Why am I going to go and shock them if they're pretty stable? Give a one-time 500 mils normal saline bolus. Well, their blood pressure's okay. I don't really see how giving the saline is going to help them. There's no signs of dehydration or anything else. And saline isn't necessarily a treatment for SVT that I know about. So I'm going to say no. Give adenosine 6 milligrams. And I like that because, I mean, they're pretty stable. They could probably tolerate it. Maybe I could reset this rhythm. But let's look at our last choice. Ask client to bear down like they're having a bowel movement. Well, what in the world would that do? Well, that's going to cause that's going to create pressure in your abdomen, known as a vagal maneuver. So this is where people, especially older people, they're sitting down, they're constipated, sitting on their toilet, and they pass out because what they've done is that when you bear down like you're having a bowel movement, it creates pressure in your abdomen. And then you have these receptors, because your cardiovascular system is so smart, that say, hey, there's too much pressure in here, bro. And so they start to lower your heart rate in order to help to compensate for all that extra pressure. So by asking the client to bear down like they're having a bowel movement, it helps to create that. So if I have a very fast rhythm, it can lower my heart rate. So this is what's called, a vagal maneuver. And it is an actual treatment for SVT, which is pretty cool, right? So for this patient, the priority action to take is going to be to start with the least invasive first, because they're stable. So I'm going to just ask them to bear down and see if that alone can do it. If that doesn't do it, then they're going to get that adenosine. If that doesn't do it, then we'll go to the cardioversion. So that's kind of the step process, all based on their stability. All right, so a client is in the following rhythm. What action is priority for this client? So first, let's interpret our rhythm, because it's asking what's priority. It doesn't tell me what the rhythm is. This is the not fun part about complexes. We just give you a patient, and we're saying you have to figure out who the patient is and then what you're going to do for them. So let's see here. So I've got a rate of 50, a little slow. I've got a fairly regular rate. I see upside down P waves. Kind of a little bit of, it's okay though. Yeah, my QRS is okay. It's just a little wonky. But I've got a QRS, I've got T waves. But yeah, I've just got this upside down P. And so anytime you see upside down, hidden, or P waves that have like a really short PR interval, that's going to be a junctional rhythm. So this is a junctional rhythm that I'm looking at. So it's saying what's action is priority. So is it going to be priority for me to check their dorsalis pedis pulse strength? Well, I might want to check a carotid pulse, make sure they're still pumping, and make sure it's not some sort of weird, like PEA, but I don't think that their foot pulses are going to help me like right now to know how things are going. I do want to check about perfusion, but I don't know about checking their foot pulses as the first thing I want to do. Auscultate clients' bilateral breath sounds or lung sounds. So this is a choice that students love to choose because they're like ABCs, but you have to make sure that the answer choice actually applies to the question. So checking their lung sounds is not going to tell me what's going on with this patient's junctional rhythm, because it's not probably a lung cause that led to this rhythm. So at the end of the day, like you always have to think about, okay, I need to get to do something for this rhythm right now. And pretty much what I probably want to do is how's the patient doing? And listening to their lung sounds isn't going to tell me how the patient's doing with this rhythm. I might look at their breathing and things like that and see how they're breathing, but I'm not lung sounds, or if their lungs are wet, coarse, crackles, wheezing, stridor, none of that stuff's going to tell me anything about this rhythm or change the outcome of this treatment for this rhythm. So none of that is going to be directly related or I should say at least commonly related to this rhythm. Look over client's current medication list. Well, I know junctional rhythm can be caused by a lot of medications, so I probably do want to check their list, but I don't know if it's the first thing I want to do. My last choice, obtain client's blood pressure and oxygen saturation. So this is a good answer, because what this is going to allow me to do is this is going to help me to see how the patient's tolerating it. So I can look at a rhythm and be like, oh my God, the patient's in VTAC, get the crash cart. But I got to see how the patient's doing. I always got to look at the patient. And again, it's not that I'm not going to treat it or do something about it, but remember how I just said that like what I'm going to do for this patient is going to depend on how stable they are. I have to measure their stability, and I can only tell how they're doing in this rhythm looking at their blood pressure and how they're oxygenating. Those are those core central measures of perfusion. So I'm always going to start there. Now, these other things, I know that I probably made it sound like lung sounds don't matter at all. They do, but they're just not my first thing for this rhythm. I've got to see, like, am I stable or not? Then I got to see what are possible causes. Are they on a med that maybe is causing this? Then I can look and do a more thorough head to toe if I need to, especially if the client's unstable. It's really going to depend on if they're stable or not, what next actions I'm going to take. But yeah, so that's the priority action. And this would go for any rhythm, whether this was junctional or different, like unless it was a rhythm without a pulse, then what I want to do is assess first and see how stable the patient is. So a nurse is caring for a client in a junctional rhythm. Which of the following laboratory values is most commonly associated with this rhythm? So what do you call it? This is again talking about junctional rhythm, but it's trying to see if I can connect. So this is like a risk factors question saying like, hey, what is associated, or which of these, if a patient had this, I would be like, they have a high chance of being in a junctional rhythm. So the first one is creatinine. It's saying an elevated creatinine. Is having kidney failure put you at risk for a junctional rhythm? Well, I don't know about too many connections between kidney failure and a junctional rhythm, so I'm going to keep going. Magnesium. And so magnesium, and this is actually a normal magnesium, if you didn't know. And so magnesium can cause, or like electrolyte imbalances in general can cause dysrhythmias, but this magnesium is normal. And, I don't think magnesium usually causes a junctional rhythm. It can cause like a beautiful ventricular tachycardia known as torsades, but aside from that. Digoxin. And if I remember correctly, the normal digoxin is 0.8 to 2.0. So this is elevated. So then I have to think about what digoxin is. So a digoxin is a medication that helps to treat heart failure. It increases your heart squeeze, and then it also decreases electricity and decreases your heart rate. So, all right, well, there's maybe a connection there. A junctional rhythm has a slow heart rate. So this could be that, hey, I might have too much digoxin, and so I'm in a junctional rhythm as a result of that. So that's a possibility. I'll hold on to that. And then white blood cell count elevated. So infection, it's possible that it could be associated with junctional, but infection is usually not the common cause of junctional. Usually junctional is the result of too much medication like beta blockers or digoxin. So the best answer here is going to be C for that high toxic digoxin level. Alrighty, last but not least, a nurse is reviewing the electrocardiogram strip of a client. What recommendation is priority at the time? At this time. So it's asking me, what am I going to call the doctor and recommend them to order? So it's effectively saying, can you identify what the problem is in this rhythm and what the solution is? And if I'm calling the physician, it may be something that's super serious. So first I have to look at this rhythm and what's off with it. So I can I see that it's regular. It's got a rate of 50, so it's slow. I kind of see a P wave. I'm going to go with that little hill as a P wave. I got this gnarly, weird little notch thing that's going on, also known as ST elevation, which happens in a heart attack. So it's saying I have an ST elevation emergency, a type of heart attack. What do I do? Like, what's my first action? So am I going to call the physician and recommend an order to draw a brain natriuretic peptide, or BNP? Well, that's that lab associated with heart failure. And it's possible we might see if they have fluid on them, but I don't think that's going to help. If a patient's having a heart attack, is this going to help save their life by drawing that lab? I don't think so. Call the physician and recommend an order for atropine intravenous push. Well, that's going to speed up the heart rate. This heart rate is low, but I don't see how that's going to help their heart attack. Like, the atropine doesn't treat the heart attack, and their heart rate might be low because of the fact that they are not getting blood flow to their heart. So I don't see how that's going to be the priority at this time. And a heart rate of 50 is not dangerously low, by the way. We usually don't give atropine for a heart rate of 50. Call the physician and recommend an order and request, sorry, there's a little bit of a double there. So request an order for a chest x-ray. Well, I'll probably want to get a chest x-ray, but that's not the first thing that I really need to do. Because a chest x-ray may tell me if there's any like outward damage, or maybe might show me if there's something else going on that might have caused the heart attack. Let me know how my lungs are doing, but it's not going to help me to treat this. Like, I really want to think about which of these is going to help me to right now treat the fact that the patient's having a heart attack. Call the physician and recommend evaluation for emergent percutaneous coronary intervention. Well, that's a fun word to say over and over and over again, isn't it? I love talking about PCIs. That's a different video, don't worry. But the D is the only answer choice that really is having me take action, have the doctor take action more than anything to actually fix this problem. So I always have to think about what's going to be most direct, or what's going to be most helpful to actually treat the problem here. And the problem is the patient's having a heart attack. So the only thing that's going to help them to treat their heart attack is going to be D, which is that they need to come in and they probably need to put a stent in, or do another emergent procedure, open up that coronary artery that is blocked. So D is the correct answer. That's it for EKG questions. I hope you had as much fun as I did. And I'll see you for the next one.